Welcome to Partners in Pancreatic Cancer. My name is Dr. Alok Khorana. I'm frequently asked, what is the current role of neoadjuvant chemotherapy in pancreatic cancer, and how do you see this possibly changing in the future? Neoadjuvant approaches, which refer to systemic or systemic plus radiation therapy upfront before resection, are increasingly becoming more common in patients with resectable and potentially resectable or borderline resectable pancreatic cancer. In the past, the standard approach was, if we think the patient's resectable, let's go ahead and resect the patient and then worry about reducing risk of recurrence afterwards. But what we've seen in the decades since Whipple surgeries and distal pancreatectomies have been offered to patients, we've seen improvements in perioperative complication rates and perioperative mortality, where patients are doing much better with the actual operation itself. But we have not seen improvements in long-term mortality. We still see a very high rate of recurrence after a major pancreatic resection. And so our approaches have changed from saying, let's go with the local treatment, which is surgery first, to saying, let's go with a systemic treatment, either systemic combination therapy or a combination of chemotherapy with radiation therapy, and just make sure that we are giving patients the benefit of the doubt in terms of controlling systemic disease first before we offer them a local operation. Sometimes these neoadjuvant approaches are formal in the form of a clinical trial. There's an ongoing SWOG study, S1505, that offers upfront either FOLFIRINOX or nab-paclitaxel to patients with that are potentially resectable. And sometimes the approaches are informal, so outside of a clinical trial where the surgeons and the multidisciplinary team feels this is not a patient that would do well or would have a high probability of margin positive disease or worse. And so let's start with systemic therapy first, see if we can downstage the patients. Let's make sure that we don't have occult systemic disease that's hiding somewhere and is not visible on scans. And once we get to the point where patients are doing well, at that point offer them resection. And so for most of our patients, I would say our approach is neoadjuvant first, generally for a period of 2 to 3 months, a small gap to allow them to recover from neoadjuvant therapy, and then resection followed by adjuvant therapy. Thank you for viewing this activity.